So my PhD topic is about heart failure and cardiac resynchronization therapy. As you heard, I'm working at Városmajor Heart Vascular Center, and my vision is to discover every single detail that can influence an outcome of a disease, with the mission of finding more personalized treatment for heart failure patients. I have two projects with the methodology of systematic review and meta-analysis. As for my first project, it's about the predictive value of scar burden assessed by cardiac MRI on sudden cardiac death in cardiac resynchronization therapy patients. The problem is that the 5-year mortality rate of heart failure patients with reduced ejection fraction can reach 50%, out of which 10 to 20% die suddenly. In the heart failure patients, there's a 6 to 8-fold increased risk of sudden cardiac death events compared to non-heart failure patients. What we know is that the scar burden is believed to be a major cause of sudden cardiac death, and the cardiac MRI is the most accurate diagnostic tool for assessing scar burden. The ICD, the implantable cardioverter defibrillator, is the gold standard therapy for sudden cardiac death. Choosing the optimal device, ICD, CRT-P or CRT-D, where D stands for defibrillation function, while P stands for the pacemaker function of these devices, could save more lives. What we miss is there's no clear evidence in the guidelines regarding the optimal device choice. Our clinical question is that what is the association between the degree of scar burden assessed by cardiac MRI on sudden cardiac death in CRT patients? Our patient population is heart failure patients undergoing CRT, while our prognostic factor is scar burden assessed by cardiac MRI. We have one outcome measure, sudden cardiac death events. Our hypothesis is that the higher the scar burden, the more effective is CRT-D in reducing sudden cardiac death events. As for clinical implication, the optimal device choice could decrease the mortality and the morbidity and lower the costs and the complication risk. We conducted our research back in November. Out of almost 10,000 articles, we found 16 eligible articles. We used the odds ratio and hazard ratio as a measure of effects, and we have one outcome, the sudden cardiac death events. Here you can see our baseline clinical characteristic table with the 16 articles. Altogether, we had more than 2,624 patients altogether, and we made a dichotomization based on the late gadolinium enhancement conducted by cardiac MRI to assess scar burden positivity and negativity. Altogether, 58% of the total population were scar burden positive, but altogether the total patient population wasn't totally homogeneous, because there were not only CRT patients but ICD patients as well. As for our first forest plot, we had a subgroup analysis for short and long-term follow-up period of the patients. We used odds ratio as the measure of effects, and we found clinically and statistically significant results, because in the scar burden positive patient population, there were 6.5 higher odds of getting sudden cardiac death events compared to scar burden negative patients. And there wasn't significant difference between the short and the long follow-up period. For our second analysis, we used univariate analysis for 12 articles with measure of effects of hazard ratio, and we found that there were almost 2 times higher risk of getting sudden cardiac death events in the scar-positive patient population compared to scar-negative ones. For the multivariate risk analysis, we find a 1.7 times higher risk for the scar-positive patients for sudden cardiac death events. And we also made a so-called competing risk model, which is has a best estimate and the highest evidence for mortality analysis. As you may see, altogether with these 3 articles, we didn't find mathematically significant, but a clinically relevant result. But there is a clear outlier, as you may see from the very wide confidence intervals and the huge difference between the different hazard ratios. It's quite interesting because Leiva's article had the longest follow-up period, and with the highest number of patients, altogether with 700 patients, with the best methodology. The reason behind this could be that they used the evaluation method of visual assessment and the for late gadolinium enhancement. And what we know is that the negative predictive value of this method is very good, more than 95%, but it has a poor positive predictive value. Basically, on those patient population where they didn't find LG positivity, there were no events, sudden cardiac death events. We also had a subgroup analysis for the CRT-only patients population and the mixed patient population of CRT and ICD. What we found is that there wasn't a significant difference between the scar burden positive and the negative patient population in the CRT-only patients population. Why is the reason behind this? The thing is that CRT has a reverse remodeling function in heart failure patients, and we know that in these patients, the incidence of sudden cardiac death events is lower. So I would like to emphasize that our strength is that this is the first meta-analysis with focusing on CRT patient population, and we have a large number of patients. But we do not have only CRT patients, and we didn't find a cutoff value for scar burden. And our initial aim was to compare CRT-P and CRT-D patients, but we didn't have enough data on that. As for conclusion, there were high scar burden is associated with 2 to 6 times higher sudden cardiac death events, and the CRT patient population has much lower scar burden. As for implication for practice, we could say that scar burden assessment could help detecting ICD candidates, and we clearly need a uniform assessment methods. And I didn't mention, but all of the articles were observational studies, so we clearly need a randomized control trial, which is just started a year ago, but we don't have results yet. As for my progress, I just about to finish my manuscript, and I hope that in the end of this week I could send for internal review. I have a second project of the diuretic effects of novel drugs compared to conventional ones in acute heart failure, but I would like to tell you more deeply in the next project meeting, progress report, in August. Thank you very much for your attention. And I'm looking forward for the questions. Thank you.
That was very good. There's no question about that. My only problem was that you didn't explain the term of scar burden. I think it's very, very, very important for the audience. So what do you mean by that?
Yes, so the scar burden, in the last few years, this term get to the knowledge of the cardiology, means that in the myocardium and the epicardium, not only ischemic, but even in non-ischemic patients, there are some fibrotic tissue which could generate electromechanical disturbances which could lead to arrhythmia. especially life-threatening arrhythmias like ventricular tachycardias and ventricular fibrillation. And the higher the proportion of these fibrotic tissues means that the higher the scar burden of the patients. Evaluating this is not easy. This term is rather a combination of these fibrotic tissues and the evaluation methods based on.
So I think it's a very, very, very important thing at the moment, and that's why I like your studies. So we'll think that the rate of the malignant arrhythmias depend on the low ejection fraction. We still think that, but maybe this is not the case. Maybe there's a much higher relationship between scar burden and the malignant arrhythmias. So it's possible that in the future we will have an idea not to put ICV into this patient population because of the higher complication rate and higher cost. So sustainable medicine, that's what we need to talk about. Congratulations, it was really very good and very interesting for me at least.
Thank you very much.